All right, first case. My name is Hank Balch. We're back in studio with our 2025 Sterile Processing Quality Improvement Expert Series. We've got Marcy.konja and Gregg Agoston from SpecialtyCare back in studio with us. Previous episode, we talked about loaner challenges. We're going to kind of step back a little bit and talk a high-level cost of errors in events. If that's loaners, if it's any inventory, if it's quality testing, you name it. If it's an error in sterile processing, we know, Gregg, those errors are caught and experienced in the operating room. So there's no such thing as an error that just doesn't go anywhere. It's going somewhere, and we want to stop it before it gets to the patient. So kind of maybe start us off, Gregg. When we say error in this context, or when we say event, what do we mean? What does this actually look like?
Yeah, so really it's anything that negatively impacts the quality of the product that's being delivered to the operating room. So kind of little refresher. We've got three primary goals for sterile processing. Instruments have to be available, functional, and safe for use. We call it AFS, okay? So that's a little acronym to remember that by. And then the challenge is that we've got to meet those three goals for each and every patient and for each and every instrument in each and every set. So it's not like the old saying, one bad apple doesn't spoil the bunch. Unfortunately, with surgical instruments, one bad instrument spoils the whole tray, right? So there's no wiggle room around it. Quality is the most important thing. And what we're trying to do is we're trying to meet the ultimate customer of SPD, which is, some people say it's the patient. It is the patient, but ultimately it's the surgeon who we're trying to satisfy, okay? Because we can deliver all the instruments we want to the room. If there's no surgeon in there to perform the procedure, nothing happens, right? So ultimately, the surgeon is your customer, and we're trying to make sure we've got the quality there for them. When quality it doesn't occur, it creates really bad things in the operating room, right? I mean, it goes, we all understand what happens in the OR, but ultimately it can create delays. And if patients are in the room and delays occur, that's a risk factor for a surgical site infection, according to the American College of Surgeons, right? The other thing is some of the errors that are occurring are contamination. So there's either something in the tray, something on the instrument, and that's another risk factor for surgical site infection, again, according to the American College of Surgeons. Those are the two primary ways that SPD negatively impacts patients, okay? You either delay the surgery, meaning they're exposed to the OR longer than they should be, and for every minute you're in the OR, your risk of surgical site infection increases. Or if we're delivering bad quality product, it could be the instrument doesn't work right that causes injury. It could be a dirty instrument that could, lead to infection, et cetera, et cetera. Or it's something that leads to a delay. Those are the primary issues. The events we're seeing, unfortunately, a lot of times are very common things that are very repetitive. And when we look at the SPD as being a production area, they're very easily solved with some very basic tools, but the primary tool is we can't solve the problem unless we've defined what that problem is. So if you, first off, do not have an event tracking system that reports timely information that is valuable to you to solve the problems, to get to root causes, then you're really missing the boat because, quite frankly, you really don't know what you're dealing with. You don't know what we don't know what errors we're trying to solve. We've gone into accounts where the manager or director of the SPD would say, well, got a pretty low rate of errors, right? We're getting called in by the executive group saying, you got to get in here quickly because we got a major problem. So tells you sometimes there can be big disconnects between what the SPD thinks is happening and what is actually occurring in the OR. And it's because there's a communication gap. There's no tool for them to report. We've seen hospitals say, well, we have a hospital incident reporting like a Midas or RL Solutions. One of the others, there's plenty of them out there. And those systems are fine. But when we looked at those systems and we've actually tracked people recording, like, okay, enter this SPD event. One, it takes too long to do it. Two, there's way too many extraneous questions that don't apply. And three, they generally don't gather the information that allows you to get to root cause to solve problems. That's a problem. People say, well, I could use SensaTrack, I could use SPM, I could use one of these other systems and do that. A lot of times those systems do have some capability for that. But again, if it's those systems aren't available in the operating room, then they can't report on it. Okay. So again, there's a gap. So what we've seen is that there's a real disconnect. And when we actually sponsored the University of Michigan College of Engineering, industrial engineers, a couple years ago, and had them do an analysis to estimate what is the cost of an SPD error. And in that time, they came back with a cost, total cost, including a potential for lost patient, lost revenue, lawsuits, lost time in the OR, et cetera, around $5,000 for every error that occurred. Okay. Because if you think about it, there's this fishbone process of like, okay, the instrument tray gets up there, somebody's got to open it up, they find a problem, they've got to call somebody to get a result, and it goes on and on. You're talking 10, 15, 20, 30 minutes. If there's a delay and they got to reprocess something, you're talking hours, or you're talking case cancel, right? Which is a worst case scenario. And the thing is that if it's a very manageable problem if you can define your problems, what you're trying to solve. But the other thing that's important to note is when we look at like tools for how to solve problems, how to long-term solve problems. The number one tool is, well, we need to educate more. Education is usually the first tool that people say, well, we need to do. The reality is education is like one of the least effective methods of changing activities, right? So the number one go-to that we use in SPD is we just need to educate more, is like the least effective method to fix something. The most effective thing is to force a function. Like, I can't close this tray until I click on a button that says I've got an indicator, I've got a filter in there, right? Those are things that could be done, but it's the errors that we see are just, there's some hospitals we're finding, and we track errors based upon how many errors occur per case performed. We're finding in some hospitals it's 20 to 25% of the cases. 5 trays that go up there, there's 1 tray that's bad. We call that a bad case because you can't do the surgery without all 5. So you've impacted the case. So we track it at like the worst case level. We're seeing 20, 25% of the cases are being negatively impacted by SPD. And that's like kind of the worst case scenario we've seen. It's a lot of them in the 15 to 20% range, but it's way too high to be truly acceptable. So there's lots of room for improvement in that.
So, Marcy, with the couple of minutes we have left, I'm curious, Gregg brought up this point of a lot of these departments may not be tracking quality events to the level they should. And they may even have this kind of misperception of, hey, it's like we're actually doing pretty good, but they feel like they're doing good because they're not really documenting what's all going on. And so there's a little courage that's needed, particularly from the leader in that sterile processing team, to be like, okay, guys, we're going to start tracking, and it's probably going to look very bad. How do you talk up that leader in that role, in that seat, understanding, hey, this is going to reflect on me as a leader, on my department. Nobody wants to feel like not effective in their role. But to Gregg's point, if we're acting like we've got it all together, but we really don't, we actually don't get the resources and the momentum that we need to make change. So what would you say to that sterile processing or OR leader that's responsible for sterile processing to say, it's going to look real bad, guys, here at the beginning as we get started, but hang in there because we got to go through the valley before we get to the mountaintop, right?
Well, Hank, that's exactly what we say because, we encourage to report on errors. We actively, proactively round in the OR to ask if there's any errors, if there's any issues, let us know. Could you fill this out? Could you give us the information? But I think it's going to make you a stronger manager and a better manager because you're seeking out that information. You're getting that information and then you're going to be able to act upon it. And when we look at, I, for years, did errors based on instrument trays processed. You could have 1% down to 0.03% of an error rate, but you're still affecting a lot more cases than that. So that's why we track to the case level, how many cases were affected. And if you work on trying to lower that by reducing those errors, finding out what's the common theme, what's the common issue. Bioburden. There's all types of bioburden. It doesn't have to be, we think of bone and tissue, blood, but bioburden is anything that's any speck that's in that tray that shouldn't be in there, that could possibly stay on an instrument and then be put into a patient in error. So those are all things that we seek out. And if you hear it as bioburden, you're thinking blood in that, but it could be something that's coming from your filters in the sterilizers, in the washers that, is coming through that you need to properly handle. And that's why digging down.
Right, right. Yeah, I'm really curious about your approach here to that case level error tracking. That is definitely not the traditional norm, to your point, Marcy. Like, you're not really seeing people in general tracking to that. But, the way you described it, Greg, makes perfect sense. Listen, if we got 5 trays and one of them is not usable, then this is a case-wide problem. It's not just a tray-wide problem. So I think that's a really unique and really powerful way to position these errors. Again, going back to the ownership theme that we talked about in the previous episode.
Hank, I'm just going to
Sure.
make one quick comment too that I think is really important for any listeners, is that the one question that you want to know, being the manager or you're working in your SPD department, what is the value that your CFO would assign to a lost minute, a minute that a tech, a nurse has spent fixing a problem? What is that price point? Because they have a cost per minute for the OR, and it ranges, right? It can be very big, it can be very expensive per minute. But you find out what that cost per minute is, because one of the key things is as you try to get resources for SPD, additional pay, additional equipment, additional supplies, etc., you've got to have some financial reason to do that. If you can show that, hey, because we don't have this equipment or we don't have this staff to do the work, it's creating errors, and those errors you told me are valued at $50 a minute, $25 a minute. Let's calculate how many errors and what is the estimated time for that, and you're going to come up with tens of thousands, if not hundreds of thousands, or even millions of dollars every year could be lost. So we're in, we some hospitals may have 6-7 months time, 1,000 errors have been recorded by the OR team. So 1,000 errors times, even if it's 5 minutes or 10 minutes times whatever price point, that number is very important. And every person that manages the SPD should know, what would the CFO charge for a lost minute of time, because that's what you're dealing with, right?
So if you're tuning in and you've got questions about this calculation, or, if you're just struggling to surface transparently the amount of errors that are happening through this workflow, because I know we've kind of focused on the sterile processing side. There's also errors that go into sterile processing that come out of the OR side that we didn't have time to jump into today. But yes, that calculation that Greg mentioned, I think, is really, really important. So if you've got questions or you're trying to work through this at the department level, that's why these experts are here. We're going to have their email addresses in the show notes of the show, and you can make sure to connect with them directly through LinkedIn. But the best news of all, we're not done yet. We've got a handful more of this series coming up. And in fact, on the next episode, we're going to talk about equipment and supply challenges, specific around how that again flows through sterile processing and the barriers or maybe even the gaps that we run into when there's not enough equipment, when it's not in the right place at the right time, on and on and on. But stay tuned with us here for next month on that, and we'll talk to you again next month.